Right, so good morning everyone. Yep, it's up there now. So I'm Wai Kiong, I'm a junior doctor. I'm specializing in hematology, where I treat patients with cancers such as leukemia and things like bleeding disorders. I'm also a bit of a geek. I quite like computers. I quite like playing with technology. In fact, in school I was quite good in math and physics, and I didn't really quite enjoy biology and chemistry, which might worry you a bit that I'm a doctor now. But somehow I ended up in medical school, and even in medical school I was looking for a way out. I thought I could do a PhD, I could do some research. But it's when I hit the wards and I would get to meet patients when I realized it was such a privilege to help people at the most vulnerable time, and meeting really inspiring healthcare professionals that showed kindness that we perhaps lose in the kind of media storm that we are in today. So then I knew that this was the place that I wanted to be. I graduated in 2003. And as you will recall, this is about the same time the national program started, so I thought this must be a really exciting time for a geek in a white coat. But somehow, every time I use a computer in hospital, this is how I feel. But that's enough for me for now. I'd like to know my audience a little bit so that I know how to communicate this. So I'm going to ask, who are you? So can I first ask, are there any junior doctors in the audience? Not bad. I think it's quite a lot more than compared to the last few years. Any other clinicians, so doctors, nurses? Excellence is nearly about 30–40%. IT/NHS managers overlaps a little bit with the clinicians. Very exciting. Software developers, coders. We've got a handful. Excellent. And anyone representing vendors as well, but not developers. Okay, about the same amount. Excellent. So, just going to take you through a short patient journey, and I think most of you will be quite familiar with this, especially the clinicians and people, of course all of us have become patients at some time of our life. So when a 17-year-old patient called Mrs. Smith comes into hospital with shortness of breath, they'll meet the A&E triage nurse, and soon they'll be met by a junior doctor. So we'll go to them and we'll take a history, find out what's going on, write it all on a piece of paper, pulling all this information from her together. After which, we'll need to input this into a computer, prescribe medications, input the vital signs into one system, order the blood results, order blood tests in another system, look at the GP discharge system to see what has previously happened to them, and then having to order the x-rays, look at the x-rays on the PAC system, which is another system. But I guess the point is that we, as junior doctors, often have to interact with multiple systems to pull all the information together to really get an idea of what we are dealing with. And then after she's admitted, we need to hand over her care to another care team. And as everyone knows, this is quite a dangerous time. We call it handover. And if Mrs. Smith becomes unwell in the middle of the night at 3 a.m., she'll be met by another junior doctor who's never met her before, having to go in the dark to try to assess her, try to pull all this information together again, having to go through all these disparate systems, including paper. Remember that we are still in a very hybrid situation at the moment, where there's some information in paper, some information in the computers. And then hopefully a clear image of what's happening to the patient will emerge and we can institute treatment. And of course, when it's time to go home, we need to do the discharge summaries and communicate very clearly to the general practitioners and to the patient what's happened. So a typical patient's journey in a hospital touched many junior doctors' lives. And it is a time of crisis and it is a time of need that we often need the most amount of information to make the best decision with our patients. And IT should really help with this, but why is it that instead of making things easier, when we junior doctors use IT, it always feels like a chore? And so I've been thinking quite a lot about this. And I've decided it's because we don't exist. You have to bear with me a little bit. So that's my conclusion. We have usernames and passwords to electronic patient records. But actually, if you look at the electronic patient record, it never actually mentions who are the junior doctors looking after a particular patient. You've got the name of the consultant who might have never met the patient before, or maybe seen the patient 4 days ago or 3 days ago, but not the junior doctor. So following on for that, the system's not really designed for us to kind of integrate all the information that we require to make decisions for the patients at the point of care. Indeed, so I work in hematology, and one of my jobs is to try to contact teams when I get a really abnormal blood result that needs urgent action. And you won't believe how hard is it to actually track down the junior doctor of the team looking after that particular patient. And often results don't get transmitted verbally, and you just hope that they see the result. So, I hope I convinced you that in the eyes of the computer system, we don't actually exist. In all the models that you go to design the databases for EPRs, there's no field for who's the junior doctor, who to contact. So have a think about that. And it's not only computers. Managers don't recognize we exist. I mean, as most junior doctors here know, and in fact consultants who've been junior doctors themselves, we are very rarely involved in the designing or procurement or feedback of any IT systems that we depend on a daily basis. And forget about IT, even on an operational level, we are often not involved in the discussion of designing the pathways of care for a patient in a hospital, even though most of the time, in the moment of crisis, moment of admission, moment of discharge, we are often the ones which are having to institute these things and have greatest influence on what goes on. In fact, we are often the bottleneck of the patient journey in a hospital. When someone calls me up to say a patient is feeling pain, it is me that needs to come and assess and prescribe. So I'm the limiting factor to getting the patient's pain relieved. So I think it's quite a bad situation in hospital where we junior doctors, with patients interact most and have most responsibility for care coordination, are not involved in the decision-making process, and I want to emphasize again, and the EPRs don't even recognize that we exist. Just going back a little bit, who are junior doctors? Probably the best way to define junior doctors is that anywhere between someone who just graduated to they become a consultant. The age range anywhere from 24 to 38 years old. And of course, with now more postgraduate medical students coming into practice, you've got even more experience and more maturity there. And like a lot of you, we have family, we are fathers, we are mothers, and we are also the age when a lot of other industries have created Google, Facebook, Apple, Microsoft. So in most other organizations, this is the age where efforts are put into cultivating and developing the skills necessary to lead organizations and services in the future. But it doesn't quite happen in the NHS, and I think we're missing a trick. How did it get this way? Now, it's very easy to sit here and blame management, but I don't think the answer is that simple. And I hope to give you a few things to think about why it has ended up this way. Now, for a lot of the non-clinicians among you, you might not realize that junior doctors are temporary staff, really. As part of our training, we change jobs a lot. Now, I graduated 10 years ago. I've worked in 4 cities, 10 hospitals, and more than 20 different departments. I'm going to be starting a new job in August, and I don't even know which hospital I'm in or which department I'm going to be in yet. Now, it's difficult to get involved in change management or to contribute to improvements in an organization when you're busy trying to learn to settle in, to keep afloat, and gain the trust of fellow work colleagues. And they need time as well to figure you out, to see whether they want to involve you. And change requires trust, requires commitment from both parties, and it's very difficult to build this kind of trust in a short period of time. So it's not really that surprising that we don't get that involved in a lot of projects in hospital. We don't stay long enough. And the other thing is about organizational allegiance. We move hospitals so much, we never build a relationship with the brand or the vision of the hospital that we are at. So it's really hard to want to contribute, to put the extra effort in to contribute to change in an organization you don't completely feel connected with. So it's definitely an uphill battle. And secondly, we all speak a different language. We don't really understand management jargon. I mean, until I got involved in quite a lot of leadership management projects, I have no idea what risk management logs, Gantt charts, business cases, or sequence are. I have no idea. And then IT has its own jargon. SNOMED, coding, databases, interfaces, data persistence, data warehousing, CD, AXDA, HL7, SQL, information governance. You get the idea. In fact, these is the kind of languages that when we try to get involved with something, people use this kind of languages to almost shut us down as an excuse, and it doesn't work very well. And lastly, we already touched on the European Working Time Directive, but we are busy. We are not supposed to be working more than 48 hours on average over a week, but hospitals are getting busier, patients are getting sicker. So what happens? You got less people on the ground, and you work harder. It's quite and I happen to go through a time before working time directives and after. And I can tell you now my intensity of work has definitely increased even in the last 10 years or so. And of course we've got exams, which I have to sit in 2 weeks' time as well. But is it worth it? I would say yes. It might be hard, but it's essential that we are involved. We are a high-achieving bunch. We are highly motivated. We are quite used to not working 9 to 5 hours, and we tend to over-deliver on what we promise. Also, we work in many different hospitals. We see how things are done well and not so well in a lot of places, so we can bring a lot of intelligence to organizations. And also because we're not permanent staff, we're not worried about our next job, we're more likely to say something when we're not happy about something. So, but most crucially, we use the cross-section of all the IT systems in the hospital under the most challenging conditions, and we got a lot to offer. So for the NHS Managers, I urge you to introduce yourself to us. We've got a lot to learn from you, and I feel we've got a lot to offer you. But please be ready to face with cynicism and suspect initially, as we're not used to being listened to. We're quite used to getting the answer no by default. But do not reinforce this cynicism by listening and then not actioning. A good tip. Think about Wi-Fi and giving us some access to the internet. That would be a good way of starting. And for goodness sake, please don't cripple the internet for us by making us rely just on Internet Explorer 7. There's a whole new world out there that we like resource from. This would be good ways to start the conversation. And to software vendors, I urge you to find ways of getting feedback and opinions from junior doctors. Speak to the clients that you are already working with to gain access to them. Run user groups, brainstorming, design sessions. We might even give you new ideas and new market opportunities that you have never thought of. But for goodness sake, don't expect us to sign non-disclosure agreements. Ideas are cheap. Execution is everything. And if you're commissioned for a new software project, demand from the people who's commissioning from you that a junior doctor gets involved. And please remember that consultants are not junior doctors. They come from a very different world. It's very quick, but you lose touch about what's really happening on the ground. And this one move will save you a lot of pain in the long run. And I've met a lot of software developers over the last few years or so, and I must say that most want to write great software and want to improve patient lives. And for those companies who are not driven by these values, all I would say is that NHS is not here to support businesses whose main goal is not to improve health. So I'm going to read this to you, and I want to see who knows who said this. My pledge is to increase the influence and role of junior doctors in improving the NHS for our patients, and over the course of next year, to dedicate specific time to shadowing junior doctors and other healthcare professionals. Anyone know who said this? If you think you are so busy that you can't come and talk to us, this was Professor Sir Bruce Keogh during his pledge during NHS Change Day, and we're trying to make this happen. And he goes on to say that junior doctors work closely with patients and alongside other members of staff on the shop floor 24 hours a day and have penetrating insights into how things really work, where the frustrations and inefficiency lie, and where safety threats lurk, and how quality of clinical care can be improved. And to my fellow junior doctors, at a recent meeting, Tim Kelsey said he's surprised the public's not more angry about the lack of transparency in the NHS. Well, I'm surprised as junior doctors we're not more angry about the kind of IT that we have to live with every day at work. We have to stop tolerating mediocrity. We need to do something about it. Now, you will never use a blunt knife to perform surgery. We should use better tools to perform our work. So, if you want to hear more about the kind of things that junior doctors are talking about, go to nhshackday.com, and the Google group is incredibly active. And I'm involved in doing some digital doctor podcasts where we hopefully talk about things that the general health IT media don't seem to talk about. And it might be a good place to start to listen to us and engage us. And that's my Twitter handle. Oh yes, and one more thing. This talk was not really about IT. It was really about developing junior doctors, the healthcare leaders for the future, so we may secure the future of the treasured institution that is our NHS. So come join us, and we are all in this together. Thank you.